if you're prepping for exams, you know there are some topics that are just guaranteed to pop up. Shigella is definitely one of them. So in this explainer, we're going to break down this classic GI pathogen into simple, high-yield points so you can walk in and absolutely ace any question that comes your way. Let's dive in.
Okay, here's our game plan. We'll start with the absolute basics. Then we'll dissect its crafty invasion playbook. After that, we'll learn how to recognize the clinical signs, how to confirm the diagnosis in the lab, and finally, we'll cover treatment and wrap it all up with a rapid-fire revision. Let's get to it.
Okay, first things first. Before we can defeat the enemy, we need to know who they are. So, what exactly is Shigella?
Let's lock in these key identifiers right now. First, Shigella is non-motile. This is huge. Unlike its cousin Salmonella, it can't swim around. That's a massive clue in the lab and a differentiator you have to remember. It's a gram-negative rod, and it's the main cause of Bacillary Dysentery. Simple, right? But trust me, every word here is pure exam gold.
So there are 4 species you need to know, and here's a super simple mnemonic. Dirty fingers bring Shigella. That's dysentery, flexneri, boydii, and sonnei. But listen, they are not all created equal. Look at the contrast here. S. dysentery is the absolute worst of the bunch, the most virulent, it doesn't ferment mannitol, and it's the one that causes nasty epidemics. Then, way down at the other end of the spectrum, you have S. sonnei. It's the mildest, it's a late lactose fermenter, and it's the one you're most likely to see in developed countries. And here's a key point for exams in India. S. flexneri is going to be your most common culprit there. These little differences, prime material for exam questions.
So here's a puzzle, right? If Shigella can't swim, how is it so incredibly invasive? Well, it's because it has a very clever strategy. Let's break down its invasion playbook. This is where Shigella's genius really shines. After it's ingested, it uses your own M cells like a secret doorway to get into the gut lining. Once it's inside, it gets eaten by a macrophage, but then it just breaks out. And here's the coolest part. Since it can't swim, it literally hijacks your cell's own actin network, building a little rocket tail to shoot itself directly into the next cell. It's a brilliant way to spread while hiding from the immune system out in the bloodstream.
If you remember one single virulence factor, please make it this one, Shiga toxin. This is the heavy artillery, and it's exclusively produced by Shiga dysenteriae type 1. Its mechanism is a classic exam question. It targets and inactivates the 60S ribosomal subunit. So what does that mean in simple terms? It shuts down the protein factory in the host cell. No proteins, the cell dies, you get vascular damage, and that leads to all the severe symptoms we see.
Okay, so we know the mechanism of attack. How does this battle actually present in a patient? What does shigellosis look like when it walks into your clinic?
The disease pretty much follows a predictable script. After a 1 to 4 day incubation period, it starts out kind of sneaky with just some watery diarrhea and a fever. But then comes phase 3, the classic dysentery. This is where you see those frequent small volume stools filled with blood and mucus, along with those painful abdominal cramps. It's a clear progression from a general illness to a very specific, very severe colitis.
And you have to be vigilant because in severe cases, especially with young kids, things can get much worse. We worry about the intestine dilating into a toxic megacolon or even perforating. Metabologically, you can see low blood sugar and low sodium. But the one that should really set off alarm bells is Eckery syndrome. This is a rare but devastating toxic encephalopathy that can lead to seizures and cerebral edema, a very high-yield and very serious complication to know.
And the story isn't always over, even after the infection clears. In patients who have the HLA-B27 gene, a post-infectious autoimmune reaction can kick in, which we call Reader's syndrome or reactive arthritis. And you are never going to forget the clinical triad thanks to this unforgettable mnemonic. Can't pee, that's for your arthritis, can't see, for conjunctivitis, and can't climb a tree for the arthritis. Just lock that one away. It's a classic. The clinical picture is pointing straight at Shigella, but in medicine, we need proof. So how do we actually confirm it's Shigella in the lab? The definitive, rock-solid answer comes from the lab. The gold standard is isolating the organism from a fresh stool sample by culturing it on selective media. This basically lets us grow the bad guy while suppressing all the other normal bacteria that live in the gut. And this is where the magic happens. On Macankey agar, Shigella is a non-lactose fermenter, so it forms these pale, colorless colonies. But the real giveaway, the smoking gun, is on XLD agar. Shigella produces red colonies with no black center. Now, why is that so important? Because Salmonella, its main differential, produces H2S gas, which creates these very distinct black centers. So no black center on XLD, you should be thinking Shigella. That's a critical visual for your practical exams.
Okay, rapid-fire memory hack time. For the key biochemical tests, we've got two super simple mnemonics. First, for the K-CoE tests, just remember the score, PN4. That stands for positive for catalase and negative for the next four, oxidase, citrate, urease, and indole. For the IMVC series, it's negative, positive, negative, negative. See the pattern? It's negative for indole, positive for methyl red, then negative for VP, and negative for citrate. It's truly the fastest way to memorize this entire profile for your exam.
So, with the confirmed diagnosis, it's time to act. How do we treat the patient and, just as importantly, prevent this from spreading?
Your treatment plan has two main pillars. First, and I cannot stress this enough, is supportive care. You must correct dehydration with oral rehydration solution. That's non-negotiable. Then, we use antibiotics. The drug of choice is ciprofloxacin. Usually a 3-day course is plenty, but remember the exception. For that really nasty S. dysenteriae type 1, you need to extend that course to 5 days.
Because Shigella is so incredibly infectious, it only takes a tiny number of organisms to cause disease. Prevention is all about hygiene. Strict, meticulous hand washing is the single most important thing you can do. In an outbreak setting, decontaminating stool is also helpful. And unfortunately, as of right now, there is no vaccine available, which makes these basic public health measures even more vital.
All right, let's bring it all home. This is your final cram sheet, everything you absolutely must know for the exam. Ready?
Here we go. It's a non-motile, gram-negative bacillus. Its deadliest weapon is the Shiga toxin, which kills cells by blocking the 60S ribosome. In the lab, you're looking for red colonies with no black center on XLD agar. Biochemically, it's catalase positive, but oxidase negative. Your classic clinical pearl is Rader syndrome in HLA-B27 patients. Can't pee, see, or climb a tree. And your go-to treatment is ciprofloxacin. Got it?
And I'll leave you with this one final thought. To test your clinical instincts, you've correctly diagnosed shigellosis. You've chosen the right antibiotic. But what is the absolute first-line, single most important intervention you must provide to every single one of these patients? The answer, of course, is rehydration. Never forget to treat the patient, not just the bug. That's all for this explainer. Study smart.